Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to the channel. Today we will discuss a university question, and at the end some other university questions we will try to analyze. The description regarding the discussion of the topic theoretically is given in the description, so you can check it out in detail, the topic there. So let's start. This is a scenario that a female 28 years of age complaining of decreased bilateral hearing, and this hearing is better in noisy surroundings but was worsened during pregnancy. Voice is quiet on otoscopy, tympanic membrane is normal, and then these are the questions which are being asked. So first we will analyze the information which is being provided in this scenario, and then we will try to answer these questions one by one. So as far as the information is concerned, here we know that this information is that this is a female patient, and she is complaining of female patient which is 28 years of age. So young female complaining of hearing loss bilaterally, which is progressively worsening, and this hearing is better in noisy surroundings, and it is worsened during pregnancy, and her own voice is quiet, and on otoscopy the tympanic membrane is normal. So when tympanic membrane is normal, it means the external ear causes for this hearing loss are automatically ruled out. Then there is no history of ear discharge, and tympanic membrane is normal and intact, so it means the chronic suppurative otitis media, etc. is also ruled out. So what we are left with is, in this, because presbycusis, if she is having sensory neural hearing loss, that is an old age disease, not as early as at the age of 28 years. So what is the most probable diagnosis? Immediately what comes in mind is otosclerosis. And why otosclerosis? Let's see. We know that otosclerosis, this is a primary disease of the bony attic capsule, which is characterized by abnormal removal of the mature bone by osteoclasts. That normally there should be mature bone which is present there, but by the osteoclasts abnormally it is removed, and then it is replaced with woven bone of greater thickness, cellularity and vascularity. A typical case of otosclerosis presents with bilateral hearing loss in more than 70% of the cases, and in this scenario the complaint is bilateral hearing loss. Then females outnumber the males, and this patient is also female. Age group which is affected typically is 15 to 45 years of age, and our patient is also in third decade, which is usually the age group affected by this otosclerosis. Histologically, this otosclerosis is present in both genders, but clinically it manifests more in women as compared to males. This increased progression during pregnancy, and in this scenario, this female, her hearing loss was worsened during pregnancy, and bilaterality is more common. So keeping in mind all these facts and clinical presentation, our diagnosis is otosclerosis. Then there is another information which is given, that is what it is, that she hears better in a noisy environment. Technically we know that this is called as paraacusis willisii, and paraacusis willisii means that the patient hears better in noisy environment, because in noisy environment a normal person will raise his voice in noisy surroundings. So this paracusis willisii is also present in this present scenario. So most common presentation, women in her 20s or 30s, conductive type of or mixed type of hearing loss, slowly progressive. More than 80% cases this is bilateral, maybe asymmetrical. Tinnitus can also be there, then vestibular symptoms in 20 to 30% of the cases. The patient's voice will be monotonous, well modulated soft speech, and our patient is also having a quiet voice. So keeping all these features in mind, the probable diagnosis in the given scenario is otosclerosis. Then next question is, what is the pattern of inheritance in this disease? It is genetically mediated by autosomal dominant with incomplete penetrance and variable expressivity. So that's why in more than 2/3 of the patients there is a significant positive family history. So then in part C, it is being asked that what would be the findings on. Actually, here they have specifically asked the findings. Even if simply it is being asked that what are the investigations, instead of writing a whole list of investigations, always write down the findings, that how you will interpret that given specific investigation and which findings on that investigation will favor your provisional diagnosis. Just simply writing down CBC, X-ray chest, or proton audiometry, or CT scan, or MRI is not sufficient. If you are writing down a CT scan, write down what do you expect on that CT scan, which will help in the diagnosis of your case. So here tuning fork tests, proton audiometry, and tympanometry. We know that in this otosclerosis there is conductive type of hearing loss. So on tuning fork test, what do we expect is that Rini test will be bilaterally negative, Weber will be lateralized towards the more affected or more diseased ear, and ABC will be normal until and unless there is cochlear otosclerosis element there. On proton audiometry, again we will expect conductive type of hearing loss. To start with, it will affect the lower frequencies, and later on all the frequencies may be involved. A typical case will show us a conductive type of hearing loss with Carhart's notch. Carhart's notch, we know that at 2000 Hertz in bone conduction there is a dip and there is AB gap is closed. That's what we call as Carhart's notch, and it is pathognomonic sign of otosclerosis. Speech audiometry will be normal except in those with cochlear involvement, of course. Tympanometry, we know on tympanometry we have got two components. One is tympanogram and the other one is stapedial reflex, and collectively tympanometry plus acoustic reflex, they constitute what we call as impedance audiometry. And in case of otosclerosis, due to the foot plate of the stapes fixation, still the compliance is higher when the pressure is equal on both sides of tympanic membrane, but this compliance is low, so that's what we call as type AS tympanogram. Type AS tympanogram. S is for shallow, that is the smaller compliance. S is for stapes fixation also, just to remember and memorize. So on tympanometry, type AS tympanogram. What are the treatment options for this disease? Now the question is treatment options for this disease. So theoretically we have to discuss all the options. In particular for this patient given in this scenario, the treatment is not being asked. So always read the statement carefully, that what is being asked. So option for this disease means otosclerosis. For otosclerosis, we know that 10% of the cases may present to you when the disease is in its active phase, and this active phase, it is called as otospongiosis, which is marked by the red hue which is visible through the tympanic membrane. That's what we call as flamingo's sign or Schwartz sign. So in those cases, to start with, we have to give to the patient sodium fluoride, so that this active disease is being converted into inactive state. Then in the initial stages, hearing aid is very helpful, and even in advanced stages where patient refuses for the surgery or is unfit for the surgery, we have to think about the hearing aid. And then is the treatment of choice is the surgery. Previously stapedectomy used to be done, nowadays stapedotomy is being preferred, or a combination of these. For example, if a patient is at otospongiosis stage, we will give sodium fluoride, and then the disease comes to at otosclerotic phase, and then we can go for stapedotomy. Or the patient, we have done the stapedectomy or stapedotomy, but if still some residual hearing loss is there, then we can go for hearing aid. So this is what it is combinations meant for. Stapedotomy, conservative procedure, so it is safer, lower rate of high frequency sensorineural hearing loss postoperatively, and the advantage of stapedectomy is that less chances of recurrence. This is another scenario. A 27 years old female developed hearing loss that was bilateral, slowly progressive, and associated with tinnitus. Pure tone audiogram revealed conductive type of hearing loss. So diagnosis again is going in favor of otosclerosis, because young female, bilateral hearing loss which is progressive, and tinnitus is also there, but pure tone is telling us conductive type of hearing loss. So then describe the differential diagnosis. I just come to that in the next slide. What will be the findings on examination and investigations? That tuning on examination, tuning fork test will reveal bilaterally Rini test negative, Weber will be lateralized towards the more affected side, ABC will be normal. On otoscopy, these tympanic membranes will be normal, or if it is at otospongiosis, then there can be flamingo sign. And then is the treatment, which we have discussed already. So differential diagnosis for otosclerosis, we have to think about ossicular chain abnormality, that may be ossicular discontinuity, or congenital stapes fixation, or Mealy's head fixation. Then some bone diseases like Paget's disease, these are generalized bone diseases, and osteogenesis imperfecta should also be considered in differential diagnosis. Now there are some MCQs regarding the same disease. That characteristic feature of hearing loss in otospongiosis include all except bilateral progressive conductive associated with deep-seated otalgia. Otalgia is not a feature of otosclerosis or otospongiosis. Rest of three, they are present there. Progressive bilateral conductive type of hearing loss in a young adult female. All are true regarding hearing loss in otosclerosis except insidious and painless, yes, bilateral and progressive, but it does not manifest in childhood. It manifests during adulthood. 15 to 45 years of age is mostly, and especially in third decade of life. Now, what is this? If some investigation is being handed over to you, don't jump over to the conclusion. First of all, identify that what it is. For example, this is a graphic representation. So there are so many graphic representations in medical field. So first we have to identify whether it is ECG, whether it is EEG, whether it is a tympanogram, whether this is a pure tone audiogram. So first of all, we have to identify this. So we know that this is a pure tone audiogram. Then we have to think about which side this is. And as you know, when there is a circle in the ear conduction, it means this is right ear. Then we have to go for what does it show, any type of loss, because the audiogram will show us either it is normal, or there is conductive type of hearing loss, or there is sensory neural hearing loss, or there is a mixed type of hearing loss. So four possibilities. either normal, conductive, sensory neural, or mixed type of hearing loss. So in this particular case, we can see that there is a AB gap, which is more than 15 to 20 decibel. So this is a conductive type of hearing loss. Then we have to go for what is the intensity of this loss, whether this is a mild hearing loss, moderate, severe, or profound. And in this case, we can see that in some frequencies it is less than 40 decibel loss, in other frequencies it is more than 40 decibel loss. So this is mild to moderate conductive type of hearing loss in right ear. So this is a right tympanogram, pure tone audiogram with mild to moderate conductive type of hearing loss, and at the same time at 2000 Hertz we can see that the AB gap is almost finished and there is a dip in the bone conduction. So this is, we know from our theoretical knowledge, that this is called a Carhart's notch. So the complete description will be right-sided pure tone audiogram showing mild to moderate conductive type of hearing loss with Carhart's notch. Then number 2 is what is the disease. We know Carhart's notch is pathognomonic of otosclerosis. So this is otosclerosis. What other investigations to confirm the diagnosis? We will go for impedance audiometry, and impedance audiometry has got two components. On tympanogram there will be type AS tympanogram and stapedial reflex will be absent. So this is how you will interpret this picture. A 25-year-old girl complains of bilateral hearing loss. She can hear better at noisy places. There is no history of ear discharge or trauma. Otoscopic examination revealed normal tympanic membranes. So, this is a 25 years old with bilateral hearing loss, and she is having paraacusis villi, which means she can hear better in noisy surroundings, and tympanic membranes are normal. So the possibility again is the otosclerosis. Tympanic membrane appears blue in all of the followings except, so early glomus tumor, hemotympanum, secretory otitis media. But in active otospongiosis, as I told you, there will be a red hue visible through the tympanic membrane which is present on the promontory, and that's what sometimes we call as flamingo sign or Schwartz sign. Again, a female 30 years old complains of hearing loss in both ears, which is more on right side. So asymmetrical hearing loss is there, progressively worsening. She also comments that hearing loss increases during pregnancy and gives positive family history also. And tympanic membrane is normal. So typical features of otosclerosis. So diagnosis is again otosclerosis. Which of the statement is not true about stapedial otosclerosis? C, because we know that the tympanogram is type AS, not type AD. Type AD tympanogram is in case of ossicular chain discontinuity. Carhart's notch is maximum or deepest at the frequency of 2000 Hertz. 2000 Hertz or 2 kilohertz. So I hope all this discussion will be helpful for you in your exams and in your clinical practice to diagnose the question, to diagnose your patients. So please like, share and subscribe the channel, and thanks for watching.